We're to the second to last talk of the day. I know it's been a long day. We're day 3 at the very end. It's a lot of information. Okay, so for the next 30 minutes, we're going to talk about the American Heart Association and do kind of a ACLS review and update. So let me ask this. How many of you have taken ACLS or been recertified in the last 3 years? So most people. Okay, so for you, you guys are going to have a little update here, a little review. And we're going to run through some of the algorithms and just point out some of the highlights just kind of as a refresher. And for people who haven't recertified or taken ACLS in the last 3 years, this will serve as an update as to what's really changed in the American Heart Association guidelines. So we're going to certify you to do CPR on squirrels and more, and then some. So some of these algorithms are really hard to see on the screen. Totally understand. So you're going to have to use your manual and look in the manual and kind of reference the algorithm as we go through. We're not going to walk through it step by step, I promise. It's way too painful. But if you're looking through the algorithm and you want to reference things, you're not going to be able to see it up here, I know. So you're going to have to look at it in your manual. But the first 2 things that we're going to touch on are the 2 algorithms that cover patients who come in, they need emergency cardiac care, but they have a pulse. So we're not talking about patients yet that have suffered a cardiac arrest that come in without a pulse. We're talking about patients who have a pulse, but they're critically ill, there's something wrong with them, and we need to do something. So we're going to talk about what the American Heart recommends in these 2 algorithms. The next lecture after mine is Diane Birnbaumer doing cardiac arrhythmias, and she's going to talk about some of this more specific arrhythmias and what the EKGs look like. This is going to talk about sort of the general concepts and what ACLS says about these different arrhythmias. So in the tachycardia algorithm in 2010 got updated, and I think it's a little bit simpler than it used to be. It basically differentiates tachycardias into recognizing whether they are narrow complex or they're wide complex in terms of their QRS complexes. And basically making that differentiation will help you decide what kind of therapies are on the menu. So on the tachycardia algorithm, you basically, first step with any of these tachycardia, whether you're talking tachycardia or bradycardia, you have to decide whether or not that arrhythmia is causing a problem with perfusion. So is the actual tachycardia, is the heart going so fast that it can't fill enough to generate enough stroke volume that you're not getting good perfusion? So that you might see a patient who has low blood pressure or isn't perfusing their brain well, so they have altered mental status, or chest pain because they're not perfusing their coronaries well, or heart failure, that kind of thing. So that's one decision to be made in the algorithm, is assessing for their stability in terms of perfusion, whether or not this heart arrhythmia needs to be intervened on emergently. If the answer to that question is yes, that I'm looking at a patient who looks like they're about to code and they've got this tachycardia up there, probably the answer in this case is electricity, is a synchronized cardioversion. And you see that on the right side of the algorithm in the blue box, synchronized cardioversion, hitting that sync button and then cardioverting them if that tachycardia is really an unstable tachycardia causing poor perfusion. They do point out that if it's a regular, narrow complex QRS, you may consider trying adenosine, because adenosine is so fast acting, it's so easy to give, pretty readily available. You can also consider that in a patient who's kind of semi-stable. Now, if they're not having poor perfusion, you're looking at a patient who actually looks okay, they've got a tachycardia, you've determined that it's not normal sinus rhythm, it's not a sinus tachycardia, but it's a tachycardia nonetheless. You decide whether it's narrow or it's wide, and then you have kind of 2 branches on that point. So that's where the second pink box, it says wide QRS, question mark. Is it a wide QRS? If the answer is no, it's a narrow QRS, it's a narrow complex tachycardia, then you have some choices, which are kind of your SVT type choices. Vagal maneuvers, adenosine, consider beta blocker or calcium channel blocker, some kind of nodal agent to slow that rhythm down. If it's a wide QRS, it's a wide complex tachycardia, then you move to the blue box on the right, which is look at an EKG, kind of figure it out. If it looks that the QRS complexes are monomorphic and it looks pretty regular, you can consider adenosine. But otherwise, if not, or you're not sure, you're going to try one of the antiarrhythmics that's mentioned here. So the choices are procainamide. The choices are amiodarone, 150 milligram a bolus, because this is somebody who has a pulse, so it's not the 300 milligram dose, or sotalol are the 3 antiarrhythmics that you can use in that scenario. So you've got a fast rhythm, you decide if it's narrow or wide, and then you work down the algorithm in those ways. Now, in terms of bradycardia, it's a lot simpler. Someone who's got a slow rate, meaning less than 50, again, assessing whether or not that slow rate is something that you need to do something about right now. And you make that decision based on the clinical presentation. Is the heart going so slow that it's making the patient sick, whether they're not perfusing their brain and are they altered, chest pain, et cetera? Is that bradycardia something that I have to do something about? If the answer is no, they actually look okay, their heart is slow, but I don't need to do something right now, in terms of the American Heart recommendations, then you just monitor and observe. You look for an etiology, you're going to support them, but you're not going to do anything right now. But if you think that that rate is actually causing them to have one of these signs of poor perfusion, then you have some choices of what you can do. This is where atropine still plays a role in the AHA algorithms. You can choose to try atropine. It's a 0.5 milligram dose. They still have a pulse, so it's 0.5 milligrams. Or you can choose to pace them. You can do that transcutaneously. You can also have the option of transvenous pacing, which is in the bottom box. Or you can try a chronotropic agent. You can try to speed them up pharmacologically. And the options that they give you here are dopamine or epinephrine are two choices. So you're faced with a patient who has a pulse, they've got a slow rate, you think you need to do something because they look sick, these are your options: atropine, pacing, or a chronotropic agent. Now, moving to the ACLS guidelines in general, what are some of the changes in the 2010 update? Well, one thing is that they've really gotten away from the ABC mnemonic, and they want you to recognize that it's probably more like CAB, that the compressions are more important than the airway when it comes to cardiac arrest. So this big emphasis on compressions you all are familiar with, that's been a major push of the American Heart in terms of even public education, that compression-only CPR plays a role, and that the compressions are probably one of the most important things we do in terms of cardiac arrest care. And in fact, we want to even look at the compressions closely, make sure that we're doing good, high-quality compressions. So they need to be aggressive, they need to be deeper, they need to be faster, and they need to not stop. So faster, deeper, don't stop is how we want to teach our compressions. So we want to go at least 100 per minute. They've got to be deeper, as mentioned here on the slide, than we used to teach it, and we don't want to stop. We want to minimize the interruptions. So in the new guidelines, they minimize the emphasis on periodic pulse checks. No more pulse checks all the time. The pulse checks are kind of unreliable. They interrupt our compressions. So you see pulse checks mentioned very, very infrequently in the new guidelines. Now, in terms of airway management, there's also been a couple changes in terms of the AHA's recommendations. One thing that's not here on the slide, but has been promoted by the AHA, is more use of supraglottic airways. So less teaching of traditional endotracheal intubation. And the reason is because there's a lot of people who are ACLS providers who don't do a lot of endotracheal intubation, and that skill is not something that could necessarily be maintained reliably if you don't do it a lot. And there's a lot of good supraglottic airways that are so easy to use and do a good job oxygenating. So they have more emphasis on the supraglottic airways. So things like LMA or things like the King LT airway that's used in the pre-hospital settings, those devices are easy to use. You don't need to maintain any skills to use them. They're blind insertion techniques. So those are newly emphasized devices. The routine use of cricoid is not really advised anymore, and there's a big push to go with capnography. So end-tidal CO2, rather than pulse ox monitoring, has been shown to be a better method of assessing ventilations. And in fact, the end-tidal CO2 readings that you get can even help you make some decisions. So for example, if your end-tidal CO2 readings are dropping, they're dropping even below 10, it's an indication that you should check the CPR. You should make sure that the quality of CPR is good, that you're getting good compressions, that perhaps you could do a little better if your CO2 is really dropping. Or, on the other hand, if your CO2 all of a sudden jumps up to 35 or 40 to kind of normal levels, it could be a sign that you actually have spontaneous circulation returning. So your end-tidal CO2 can give you a lot of information, so more emphasis on capnography. And in fact, these little colorimetric indicators that we use a lot are really recommended only if you don't have capnography. These aren't perfect, they've got their problems, and so if you don't have capnography available, you can use these, but these are being de-emphasized in the new AHA recommendations. The other big thing in the updated AHA recommendations is a de-emphasis on the drugs. We all know from in the last 10 years, different papers showing us that the drugs in CPR and ACLS just aren't working. The epinephrine, the atropine, all these drugs that we use with patients in cardiac arrest don't improve outcomes. They don't improve neurologic outcomes, which is really what we're going for. So there's a major de-emphasis on the drugs, on the timing of the drugs, the dosing. Let's just not pay as much attention to that. Let's talk talk more about compressions is kind of the AHA's approach to this. So there's just not a lot of data to say that the link in the chain of advanced cardiac support, the drug link in the chain is probably one of the weaker links, not as effective as we once thought it to be. Atropine was actually taken off of the algorithms for pulseless electrical activity, or PEA, and asystole. You don't have atropine on those algorithms at all anymore, where it used to be. It's not there. We'll see those in a little bit. And there's more emphasis on maybe looking at regionalizing post-resuscitative care. We'll talk more about that as well. So again, going back to your manuals, because you're not going to be able to see this on the screen, but this is the algorithm for an adult with cardiac arrest. And what you'll see as you work through this algorithm, which we've just talked about, is there's a big emphasis on compressions. They've gotten rid of the look, listen, and feel when you first approach a patient. You just go ahead and start compressions. You get going with the compressions until you can look with a monitor to see if you have a shockable rhythm. We know that electricity is one of the more effective interventions. So we're going to look to see if we can get in there with electricity, if it's a shockable rhythm, if it's VF or VT. If it is, we're going to go that route. We're going to shock. And as soon as we shock, we don't check for a pulse or check rhythm. We go right into CPR. That's a new change in 2010. So your cycle is CPR, look for a shockable rhythm, go right into CPR. And then you can see that epinephrine starts to enter the pathway there on the VF-VT side. So you're doing 2-minute cycles of CPR, you're assessing the rhythm to see if it's shockable, and you're going down that pathway. If you find yourself in sort of a cycle of VF-VT that's refractory, that you're giving epinephrine, you're trying to shock, you're doing CPR, and you just keep coming back to the same rhythm over and over again, there is a role there for amiodarone, if you see that at the bottom of the algorithm there on the left-hand side. So amiodarone can be used for refractory VF and VT in the cardiac arrest algorithm if nothing else is working. If you find yourself onto the asystole and PEA side of things, basically you're left with CPR. You can try some epinephrine or vasopressin, a vasopressor essentially, and then you've basically got to look at your 5 H's and your 5 T's, and you've got to think about what kind of possible reversible causes you may be dealing with, and if there's any therapy that you can offer this patient to turn things around. So while you're doing your 2 minutes of CPR and you're doing your epinephrine, you're thinking through your H's and your T's, and you're thinking through whether or not there's any therapies that you can offer this patient. And you're kind of doing it in a systematic way. You're going through them systematically. You're thinking about whether this could be hyperkalemia, for example. Can I offer this person calcium? Can I throw an ultrasound on the chest and look for tamponade? Thinking about all the possible things that you could actually intervene and do something to turn this cardiac arrest scenario around. Now, this little circular algorithm also emphasizes how important the American Heart thinks compressions are. So again, if you find a patient who suffered an arrest, you're going to enter this algorithm by just starting CPR, looking for a shockable rhythm, and then you just basically go around and around in 2-minute cycles. In the middle, basically offering them epinephrine. You're considering an advanced airway, a supraglottic airway. You're going to think about the reversible causes. You're thinking through your H's and your T's. You're looking whether or not there's anything shockable as you check it. And that's basically what you're going to do. Around and around you go in these 2-minute cycles, thinking about your H's and T's. And that's kind of the circular idea of the algorithm, with CPR being a very, very major part of that. Now, this slide's a kind of a busy slide, but it goes over a lot of the overview of the different guidelines in 2010, including some of the stroke recommendations and some other little mnemonics and things. You can look at that through your leisure. I'm not going to walk you through that right now. You can certainly glance through that, but we've covered a lot. That's already on this slide already. Now let's talk a little bit about post-resuscitative care, because this is a really big thing and a new area that the AHA has been promoting and we've been learning more and more about. And this is probably one of the bigger changes in ACLS in the past 10 years or so. So the American Heart, based on data that we've been looking at over the last decade or so, is now starting to promote the idea of regionalization of post-resuscitative care to STEMI centers, recognizing that a lot of patients who suffer a cardiac arrest have suffered a coronary event. A lot of these people have had an MI or some kind of cardiac arrest due to a coronary event, and that these patients might benefit from cardiac catheterization and angiography early on in their care. Again, the idea of looking for something that we can do something about. And if in fact this could benefit somebody, then getting them to it earlier might be better. So that if we could regionalize that, recognizing that not every hospital can have all that expertise, maybe we need to know who does and who doesn't and send people to one place or the other. This is one thing that the American Heart is starting to promote the idea of. A little bit controversial, but something that's out there. The AHA has certainly also started to promote the idea of therapeutic hypothermia for those patients where we do get spontaneous circulation back, but they're not waking up. They're not getting their neurologic function back, but we did get a pulse back. Those patients will probably benefit from hypothermia from the data that we have. That's also being promoted now by the American Heart. We know that post-arrest, looking at EKGs, we can make some determinations about whether or not somebody suffered some kind of cardiac event. And then to also employ consistent, systematic approaches to looking through those H's and T's and looking for reversible causes is a big part, we think, in terms of improving outcomes. So in terms of the therapeutic hypothermia thing, how many of you are working at a place where you have a protocol to institute therapeutic hypothermia? So a chunk, but not everybody. And we have that going at our place now too. The trials and the evidence that point to hypothermia are not perfect. There's a lot of criticism of the evidence that promotes therapeutic hypothermia. There are some small randomized controlled trials. Some of the studies are sort of before and after type studies, meaning that they looked at their survival before therapeutic hypothermia in terms of cardiac arrest survival, and then they employ therapeutic hypothermia and they look to see how things perform afterwards. And most of this evidence has been fairly positive. The other part about therapeutic hypothermia is that it's cheap. You know, giving someone cold saline or ice packs is an inexpensive therapy, and if it's beneficial in a population where the outcomes are really, really poor, if we can get any kind of a bump in terms of good outcomes, it'd probably be worth it. So in terms of the upside to therapeutic hypothermia, there's a lot of upside and not a lot of downside as far as most people see it, so why not give it a try? The stakes are very high, and so if hypothermia can be employed, and if it makes a difference in terms of neurologic outcome, which is really what we're going for, why not, is kind of the attitude. You'll see charts like this in a lot of the data, basically looking at all the outcomes when it comes to resuscitation literature. We look at survival to admission to the hospital, survival to discharge from the hospital, survival in terms of neurologic outcome, and when you look at hypothermia, it seems to have trends towards the positive. The questions about hypothermia that remain involve mostly the particulars of hypothermia. How long do we keep them cold for? What temperature exactly are we shooting for? Those kind of specifics about this therapy really do remain unanswered. So we don't know really what the ideal protocol for hypothermia is. We just think that it's the right idea when it comes to post-cardiac arrest care when we get circulation back and they're not waking up. So in terms of post-resuscitative care, some other concepts are questions like this, which is, I've got somebody who had an arrest, I've got circulation back, should that person go for a head CT? Could it have been an intracerebral event? And the answer to this question is they probably not routinely. There is some evidence, this study that's mentioned here, where about 20% of post-arrest patients had a head CT done, and this was a retrospective study looking at patients who had some kind of indication that they had a neurologic event. So they may have had a seizure or they have some kind of a neuro sign. And in those patients, they did find some patients that had positive head CTs, but certainly not a blanket statement yet to say that anyone who's had a cardiac arrest needs to go for a head CT. Not endorsing that statement yet. But selectively, yes, someone who you think you have some kind of clue that it was a neurologic event might benefit from a head CT. Certainly, we know that clues that we can get from ultrasound can be really helpful. So early echocardiogram can tell you a lot. Think about it, with the H's and the T's, we've got tamponade as one of our T's. So throwing an ultrasound on the chest and finding a pericardial tamponade, now that's an unusual case, but if you find that, you can do something about that and you can turn things around. So throwing an ultrasound on the chest and getting some information can really be helpful. In addition, what about the T of thrombosis that we ask ourselves? Well, if they've got a big PE, we can see on a quick ultrasound, a quick echo, that the right side of their heart is dilated. That might give us a clue that it's a big PE. We can also look, for example, after the arrest has happened, and look and see what that heart is even doing, because we know that if you throw the ultrasound on and the heart is just sitting there, not doing anything, there's just not much that we can do to get that thing going if it's just sitting there. So if you have a heart that's really kind of trying, you can get a lot of information to look at the pump and see what the pump is doing. So that is probably something that we should recommend. How about just giving empiric TPA? Sometimes this comes up as we think through our H's and our T's. We think, well, there's thrombosis, and maybe I should just give TPA. Is there any evidence to support giving empiric TPA? And the answer is no. It's really mixed results. Certainly, if you were in a place that can do PCI, angiography, and do an intervention, giving TPA in that setting probably not helpful, harmful. Remember, the risk-benefit equation for TPA is a very, very tight balance. And so certainly the evidence has been very, very mixed, so no endorsement of empiric TPA. How about kind of cutting-edge technologies? What are we looking at in the future? What are some of the things that the experts in resuscitation are talking about? Well, one is about, should there be a parallel between sepsis care and early goal-directed therapy in sepsis care and post-cardiac arrest care in the AHA? And really, the answer there is we're not really quite ready to go there yet. And in fact, all the expensive catheters and the emphasis on looking at mixed venous saturation, oxygenation in terms of sepsis care has been called into question as well. And there's studies going on to look whether or not we really need to do those invasive type monitorings with sepsis, whether it matters in terms of outcomes. And so there's no evidence at this point in terms of post-resuscitative cardiac care that kind of invasive measurement would make any difference in terms of outcomes. Another thing that's out there is about glucose control. We know that patients who have had a cardiac arrest and have hyperglycemia, it tends to be associated with worse outcomes. Doesn't mean that it causes worse outcomes, but it tends to be associated with them. So should we be controlling glucose more tightly? Should we be putting these people on insulin drips, et cetera? And we just don't know whether or not controlling their glucose will make a difference, if it will actually improve outcomes, or maybe it's just a sign of a patient who's going to do worse in the end. And then what about seizure control? There is a small percentage of patients who've had a cardiac arrest who go on to have a seizure, and certainly that wouldn't be good for their neurologic outcome. So should we be doing post-arrest seizure prophylaxis with medications or EEG monitoring? We don't know if they're awake or not. They're unconscious, they're intubated. Should we be monitoring them for seizures? And again, this is an area that's being looked at. And then the last one is about ECMO, or extracorporeal membrane oxygenation, which is essentially the idea is somebody's gone into cardiac arrest, should we put them on bypass? Would that be something that we could do? While we try to intervene, while we think about what's going on, go through our H's and T's, what about putting someone on ECMO? And in fact, there are places that are doing this and papers that have been written about this with some pretty amazing stories of people going on to ECMO and then being, getting an intervention done and waking up completely neurologically intact because they've been oxygenated essentially. And that's a pretty amazing and interesting technology if it could be done. What about the resources? What kind of equipment do I need? All of these questions are valid questions. So ECMO in this setting, we call it resuscitative ECMO, or RECMO for short, in terms of ECMO in the resuscitative arena. What does ECMO look like? It looks like this. This certainly doesn't look simple. I'm sure you can see that. It's sort of akin to dialysis in the sense that you're going to put in two big cannulas, you're going to take blood out, you're going to run it through a system that oxygenates it and heats it and hemperidizes it so it doesn't coagulate. You're going to put it back in the body. And this does require definitely some specialized equipment and some specialized resources. And what are those cost-effective things in terms of outcomes? Those are all questions that remain, but it is something that some centers are doing and certainly talking about in the resuscitation world. So just kind of pulling all this together in terms of post-cardiac arrest care algorithm, looking at the algorithm in your manual, there's a couple ideas here just to review. So you have somebody who's post-cardiac arrest, you've gotten circulation back, we're going to optimize their ventilation and oxygenation. There's another concept here, which is that one, we want to not hyperventilate people. We know that that's not good for them physiologically. And also, we recognize that oxygen has its own toxicities. So putting someone on a vent at an FiO2 of 100% just in, forever is not a good thing. We don't need to keep them at that level of oxygenation. We want to actually titrate that FiO2 down as soon as we can. We want to keep them at a decent pulse ox, but they don't necessarily have to be at 100%, and perhaps we're not doing them any favors with that. So then we're going to move on to treating any kind of hypotension that comes up. That's not going to help us in terms of perfusion. So we're going to use any vasopressors that we might need to use, giving them boluses, is, checking an EKG. And then if they wake up neurologically, we're going to decide whether or not they need to go for any kind of PCI. Have they had a STEMI? Do they need some kind of coronary intervention? And if they don't wake up neurologically, we're going to initiate hypothermia protocols, and they can have a hypothermia protocol initiated and still go to PCI. Those two things can go together. And then we're going to move on to our advanced critical care. So some interesting post-cardiac arrest care algorithm ideas there, things that we didn't used to think about, things that we didn't necessarily know were so important that now we do know are important. So the last slide here is about proposals for regionalization, and this may get some of you a little bit irritated that we're even talking about regionalizing more things, but the concept here, as alluded to before, is that in the post-cardiac arrest patient who does get circulation back, they've probably had a cardiac event, and should they be going to a place that can do PCI and you could have an intervention? If it were you and you had a cardiac arrest, would you want to be going to a center that had PCI available to do an intervention if that's what you would need? Now, the proposal from the American Heart would be that this is something that you wouldn't necessarily just declare yourself as a hospital to be a level 1 or level 2 center, that the American Heart would come and credential you, just like the American College of Surgeons does for trauma centers, that an external body would come and certify you as a level 1 or level 2 center, depending on what your resources are. A level 2 center would be somewhere that doesn't have all the resources, doesn't do PCI, but they could start hypothermia, and they would have a protocol to transfer to a place that needs PCI if the patient needs that. And a level 1 center would be somewhere that is basically a STEMI center, somewhere that they're doing cardiac catheterization 24/7 with extra capabilities, such as electrophysiologic capabilities. If someone needs a defibrillator implanted, for example, if they have some kind of a arrhythmia that needs to be treated, they would have that capability. And this would be a place that would do frequent resuscitations like this. We know that centers that do a lot of these types of procedures tend to have better outcomes, so they would have to demonstrate that this is a place where they regularly encounter this type of thing, and they're pretty good at treating it. So after that whirlwind tour of ACLS, you are now officially qualified to resuscitate all pets, animals, anyone around you. You're ready to go, and I thank you for your attention.